Hello everyone, today we'll be talking about urinalysis. As per se, urinalysis is a very simple test that is commonly ordered daily thousands of times in our hospital. So urinalysis is used as a screening and a diagnostic tool to detect substances or cellular material in the urine associated with metabolic disorders, renal dysfunction, or urinary tract infection (UTIs). Often, substances such as protein or glucose will begin to appear in the urine before patients are aware that they may have a problem. So urinalysis, bedside analysis you can do is urine color, urine transparency, urine odor, and you can do a dipstick urine analysis. So dipstick urinalysis is our focus today. A total negative dipstick test is associated with negative microscopy in 90 to 95% of cases. False negative rates are 5 to 10%. So basically this is the urinalysis. These are the dipstick sticks and this is the bottle. So the parameters that are included in a urinalysis bottle are leucocytes, nitrites, protein, pH, blood, specific gravity, ketones, glucose. Then urobilinogen, bilirubin are also included. Specific gravity range is 1.002 to 1.035. Specific gravity of urine is a measure of the amount of solids dissolved in urine as compared to water. The specific gravity of water is 1.000. Specific gravity measures the ability of the kidney to concentrate or dilute the urine and is directly proportional to urine osmolality. Solid concentration. Specific gravity between 1.002 and 1.035 on a random sample is normal if kidney function is normal. So decreased, less than 1.005. Refers to inability to concentrate urine or excessive hydration, such as during volume resuscitation with IV fluids, nephrogenic diabetes insipidus, acute glomerulonephritis, pyelonephritis, acute tubular necrosis. Note: if specific gravity is not greater than 1.022 after a 12-hour period without food or water, renal concentrating ability is impaired and the patient either has generalized renal impairment or nephrogenic diabetes insipidus. Falsely low specific gravity can be associated with alkaline urine. Fixed specific gravity of 1.010. The glomerular filtrate in Bowman space ranges from 1.007 to 1.010. Any measurement below this range indicates hydration and any measurement above it indicates relative dehydration. In end-stage renal disease, specific gravity tends to be towards 1.010. Chronic renal failure, chronic glomerulonephritis lead to a specific gravity of 1.010. Increased specific gravity of greater than 1.035. Increased specific gravity indicates a concentrated urine with a large volume of dissolved solids. This may be due to dehydration such as fever, vomiting, diarrhea, syndrome of inappropriate ADH secretion, adrenal insufficiency, prerenal renal failure, hyponatremia with edema, liver failure, congestive cardiac failure, nephrotic syndrome. Elevation in specific gravity also occurs with glycosuria, for example diabetes mellitus or intravenous glucose administration, proteinuria, IV contrast, urine contamination, low molecular weight dextrin solutions such as colloid or that are colloids. So the second parameter we'll talk about is pH. pH range 4.5 to 8.0. The kidneys play an important role in acid-base regulation within the body to maintain a normal urinary pH range between 5.5 to 6.5, but it may vary from as low as 4.5 to as high as 8.0. The glomerular filtrate of blood plasma is usually acidified by renal tubules and collecting ducts from a pH of 7.4 to about 6 in the final urine. Control of pH is important in the management of several diseases including bacteriuria, renal calculi, and drug therapy. High urinary pH, which is alkaline urine. This may be due to vegetarian diet, low carbohydrate diet, or ingestion of citrus fruit. Although citrus fruits are acidic, the digestion process leaves an alkali ash. systemic alkalosis, metabolic or respiratory, renal tubular acidosis, Fanconi syndrome, urinary tract infections, drugs such as amphotericin B, carbonic anhydrase inhibitors, sodium bicarbonate salicylate, still ammoniacal sample that is left standing. Low urinary pH or acidic urine can be due to high protein diet or fruits such as cranberries. Systemic acidosis, metabolic or respiratory, diabetes mellitus, starvation, diarrhea, malabsorption, phenylketonuria, alkaptonuria, renal tuberculosis. So the third parameter is proteins. Normal daily protein excretion should not exceed 150 milligrams in 24 hours or 10 milligrams per 100 ml. Proteinuria is defined by the production of greater than 150 milligrams per day, with nephritic syndrome producing greater than 2.5 grams of protein in a day. Dipstick Urinalysis detects protein with bromophenol blue indicator dye and is more sensitive to albumin and less sensitive to Benson's proteins and globulins. Test positive results are equivalent to 10 milligrams per 100 ml or about 150 milligrams in 24 hours, which is the upper limit of normal. So true protein elevation is due to renal causes such as increased renal tubular secretion, increased glomerular filtration rate, nephrotic syndrome, pyelonephritis, glomerulonephritis, malignant hypertension. Cardiovascular system causes are benign hypertension, congestive cardiac failure, SVA, functional proteinuria, which is albuminuria, to fever, cold exposure, stress, pregnancy, eclampsia, congestive heart failure, shock, severe exercise, other orthostatic proteinuria, electric current injury, hypokalemia, Cushing syndrome. Drugs, aminoglycosides, gold, amphotericin, NSAIDs, sulfonamides, penicillin. Note: Benson's globulin associated with multiple myeloma, lymphoma, and macroglobulinemia is not detected by dipstick urinalysis. So basically, this is a table that is showing you the results of protein in urine and the values. Leucocytes, white cell count, determines the presence of whole or lysed white cells in the urine by detecting leukocyte esterase activity. A positive leukocyte esterase test correlates well with pyuria. However, the diagnosis may be missed in up to 20% of cases if a negative urinalysis dipstick is used to exclude UTI. False positive may be due to contaminated specimen, Trichomonas vaginalis, drugs or foods that color the urine red. False negative can be due to intercurrent or recent antibiotic therapy. Glycosuria, proteinuria, high specific gravity, low bacteria count UTI, especially in women. Nitrates. Nitrates in the urine are converted to nitrates in the presence of gram-negative bacteria such as E. coli and Klebsiella. A positive nitrate test is a surrogate marker of bacteria. Positive test strongly suggests infection, but negative test does not exclude it. False negative may be due to drugs or foods that color the urine red. Certain bacteria such as S. saprophyticus, Acinetobacter, and most enterococci. Blood. Dipstick urinalysis is able to detect hemolyzed and non-hemolyzed blood in the urine. The pseudoperoxidase reaction of erythrocytes, free hemoglobin or myoglobin catalyzes chromogen oxidation on the dipstick to produce a color change. A positive result may be indicated of hematuria from trauma, infection, inflammation, infarction calculi, neoplasia, clotting disorders, or chronic infection. Hemoglobinuria may be associated with intravascular hemolysis, burns, sudden cold, eclampsia, sickle cell crisis, multiple myeloma, alkaloids such as mushrooms, and transfusion reactions. Ketones. Ketones such as acetone, acetoacetic acid, beta-hydroxybutyric acid are the endpoint of incomplete fat metabolism. They accumulate in the plasma and are excreted in urine. Ketonuria is associated with low carbohydrate, high fat or protein diet, starvation, diabetes, alcoholism, eclampsia, and hypothyroidism. Ketonuria is also associated with overdose of insulin, isoniazid, and isopropyl alcohol. Most urinalysis reagents tests utilize the nitroprusside test, which is most sensitive to acetoacetic acid, less sensitive to acetone, and not sensitive to beta-hydroxybutyric acid. Some false positive may be due to heavily pigmented urine. Drugs such as captopril, levodopa, salicylates, phenothiazines. False negatives may be due to negative nitroprusside test for ketonuria. Underestimate the presence of ketonemia due to increased beta-hydroxybutyric acid concentrations. Glucose. Glucose is not normally present in the urine, with less than 0.1% of glucose normally filtered by the glomerulus appears in urine, less than 130 milligrams in 24 hours. Glycosuria occurs in patients with elevated serum glucose or in the presence of a reduced renal threshold and reduced glucose reabsorption in renal tubular disease and pregnancy. Glycosuria also associated with certain drugs such as cephalosporins, penicillins, nitrofurantoin, methyl-dopa, tetracycline, lithium, carbamazepine, phenothiazine, steroids, and thiazides. False positive may be due to hydrogen peroxide or bleach. False negatives can be due to ascorbic acid, vitamin C, or fruit juices. Some dipsticks are affected by increased specific gravity and ketonuria. Note: dipsticks implying the glucose oxidase-peroxidase reaction. For screening are specific for glucose but can miss other reducing sugars such as galactose and fructose and are not suitable for testing newborn and infant urine. Instead, use a modified Benedict's copper reduction test. Bilirubin. Bilirubin is not present in the urine of normal healthy individuals. The presence of bilirubinuria may be an early indicator of liver disease and occur before the clinical signs of jaundice develop. Bilirubin is formed as a byproduct of red blood cell degradation in the liver and then conjugated with the solubilizing sugar, glucuronic acid, and excreted in bile. Within the intestine, the bilirubin is converted into stercobilin, excreted in feces, and urobilinogen excreted by the kidneys. Failure of conjugated bilirubin to reach the intestines, for example due to biliary obstruction, will result in bilirubinuria. Note: only conjugated bilirubin can be excreted as bilirubinuria. A positive test for urine bilirubin confirms conjugated hypobilirubinemia. Race conjugated bilirubinemia with bilirubinuria is associated with hepatocellular disease, cirrhosis, viral and drug-induced hepatitis, biliary tract obstruction such as cholelithiasis, pancreatic causes of obstructive jaundice such as carcinoma of the head of the pancreas, and recurrent idiopathic jaundice of pregnancy. False positives may be due to phenothiazines. False negatives may be due to ascorbic acid, aged sample, rifampicin, and exposure to UV light. Urobilinogen is normally present in the urine in low concentrations, 0.2 to 1 milligrams per deciliter or less than 17 micromoles per liter. Bilirubin is converted to urobilinogen by intestinal bacteria in the duodenum. Most urobilinogen is excreted in the feces or transported back to the liver and converted into bile. The remaining urobilinogen, less than 1%, is excreted in the urine. Urobilinogen is present in increased concentrations in the urine in patients with cirrhosis, infective hepatitis, extravascular hemolysis, hemolytic anemia, pernicious anemia, malaria, and hepatitis secondary to infectious mononucleosis. Very sensitive but non-specific tests to determine liver damage, hemolytic disease, and severe infections. Urobilinogen levels are decreased or absent in obstructive jaundice and elevated levels of bilirubinuria. So bilirubin normally is negative. In biliary obstruction it's positive, in hepatic disease it's positive, and in hemolytic disease it's negative. Urobilinogen normally is positive. Biliary obstruction it may be negative or decreased. In hepatic disease it's negative or decreased, and in hemolytic disease it's increased. So basically this is a paper that's showing the normal urinalysis parameters and the time after which you should read. So after we get our urine dipstick, we actually dip it in urine, and after removing we have to wait for the required amount of time that's mentioned here before we start reading. So for albumin it's 30 seconds, glucose, bilirubin 30 seconds, ketone, sorbate is 40 seconds, specific gravity 45 seconds, blood 60 seconds, pH 60 seconds, protein, urobilinogen, nitrate 60 seconds, and leukocytes 120 seconds. So after you get it, you have to place it and you start reading from down going up. Then according to the color, that's how you write down your results. So this is a summary of everything that I've been talking about, but it's not very clear on the video. But if you're interested, you can just send me a message and then I'll be able to send the PDF. You'll be able to read this properly. So this is a rough example showing a urinalysis result. The normal color of urine is yellow, clarity is supposed to be clear, bilirubin negative, specific gravity should be between 1.003 to 1.030, alkyl blood negative, pH 4.5 to 8, urobilinogen 0.221, nitrate negative, leukocytes negative, glucose should be negative, ketones should be negative, proteins should be negative, white blood cells, red blood cells, epithelial cells, bacteria, everything should be negative. So that's all about your analysis. If you like the video, please like and subscribe. If you're interested in the PDF, please just comment and then I'll be able to send you the PDF. Thank you.